please help me welcome Dr. Randall Curtis.
Well, thank you for that nice introduction, and I'm really delighted to be here with you this afternoon and talk a little bit about the role of palliative care and organ donation, and view this as an opportunity for a collaboration. I don't have any financial conflicts of interest to disclose, but I do want to talk about the funding for our research and for our Palliative Care Center of Excellence. We have funding from UW-Medicine, which has really made palliative care a priority in its strategic plan and its initiatives. We also have received significant funding from the Cambia Health Foundation. And in fact, we are now the Cambia Palliative Care Center of Excellence at UW-Medicine. And then our research is supported by the National Institute of Nursing Research, National Heart, Lung, and Blood Institute, and the PCORI, or Patient-Centered Outcomes Research Institute. So what I thought I would do for you during this talk is to define palliative care and describe how it helps patients and families, to describe how we're doing and the lessons we've learned in trying to improve palliative care, and then to discuss the potential for collaboration between palliative care and the organ donation process. The definition of palliative care that I like is the one that was developed by the Center to Advance Palliative Care. Palliative care is specialized medical care for people with serious illness, focusing on providing relief from symptoms, pain, and stress of a serious illness, whatever the diagnosis. That the goal is to improve the quality of life for the patient and their family. It's provided by a team of doctors, nurses, and other specialists who work with the patient's other doctors to provide an extra layer of support. And it's appropriate at any age and at any stage in a serious illness and can be provided together with curative treatment. So this is a very broad definition of palliative care, and under this definition, a lot of you will recognize the care that you provide, and that's a big part of our point. Palliative care is not restricted to palliative care specialists. In fact, all clinicians who touch the lives of patients with serious illness and their family are in fact providing palliative care. The goals are around communication about the patient's values and goals and making sure that our care matches the patient's goals, symptom assessment and management, provision of emotional and psychological and spiritual support to patients and their families, coordination of care across diverse care settings, and importantly, grief and bereavement support both before a patient's death as well as after. And this definition, I think, is important in that it recognizes that palliative care is much broader than end-of-life care and hospice care. End-of-life care and hospice care are very important components of palliative care. But palliative care, if we equate palliative care with end-of-life care, then we miss enormous opportunities to improve palliative care for patients and their families before we recognize that they are imminently dying. End-of-life care, again, very important part of palliative care, but just part. And hospice is a really important modality or model for delivering end-of-life care to patients, generally in their home or in hospice facilities. And this definition, I think, encourages us to think about palliative care as both primary palliative care, the care provided by all clinicians who care for patients with serious illness and their families, and specialty care, the care provided by palliative care specialists, which by definition is an interdisciplinary team that includes physicians, nurses, social workers, spiritual care providers, and others. And I think what we're trying to avoid is what's shown here, where patients see a doctor and the doctor says, "There's no easy way for me to tell you this, so I'm sending you to someone who can." You know, this won't work. It won't work in the outpatient setting. It won't work in the acute care setting. It won't work in the ICU. We really need to make sure that everyone who takes care of these patients and their families has basic palliative care skills. There's been some research recently that really has highlighted the value of palliative care. One of the most important studies was this one, published in the Journal of Medicine 5 years ago now, a randomized controlled trial from the Massachusetts General Hospital, where they identified patients with metastatic non-small cell lung cancer and randomized them to either routine palliative care up front or usual care at the Massachusetts General hospital, which is pretty good care. What they found is that early palliative care improved quality of life. This is TOI is a commonly used quality of life scale in cancer research. Significantly higher quality of life for those randomized to early palliative care. It reduces symptoms, in particular depression, using two measures of depression, the HADS-D and the PHQ-9, significant reduction in depression. And to the surprise of the investigators who did this study, those randomized to early palliative care lived longer. They lived significantly longer. In fact, at the time this study was done, this survival benefit was better than the chemotherapy that was used in these patients. If this were a drug, we would be FDA approved, and we would be making a lot of money. We're not FDA approved, and I'll leave you to figure out how much money we're making. But you could ask, well, how does palliative care improve survival? And I don't think that's true in all diseases and all illnesses. But when patients receive chemotherapy in the last 2 weeks of life and their functional status is very poor, you can begin to see how talking to them about the value of chemotherapy in that setting could actually cause them to choose less chemotherapy, and they might actually live longer and have a higher quality of life. So what is this? What do these palliative care providers do? It's a little hard to know from this study. People talk in palliative care meetings, we talk about what's in the syringe, what's in the palliative care syringe. But the investigators in this study did a cool thing. They went back and they looked at the notes written by the palliative care provider for patients randomized to the intervention. They randomly selected 20 patients who were randomized to the intervention. They went through the notes using qualitative analyses, and they identified the key elements that these providers said that they were providing. And I think you'll recognize a lot of these things as basic palliative care, as things that should be done as part of both primary and specialty palliative care. Relationship and rapport building, addressing symptoms, addressing coping, establishing an illness understanding, discussing cancer treatments, end-of-life planning, and engaging family members. And studies like this, and there have been others, have really led to a dramatic increase in palliative care programs, palliative care consult services in hospitals, and now we're beginning to see increasing outpatient palliative care programs as well. This is data looking at the number of hospitals that have a palliative care consultation service or a palliative care team from 2000 to 2012, dramatic increase. In 2000, about 45% of hospitals over 250 beds had a palliative care service. In 2012, it was about 85%. So really been increasing dramatically. There's also been interest in looking at the effect of palliative care and hospice on healthcare spending. This is a report from the Congressional Budget Office that was released in August 2013. They were looking at the reduction in Medicare spending growth. So not reduction in Medicare spending, but reduction in Medicare spending growth, and trying to understand what that was due to. Their analysis, they decided it was not due to the recession, and that it was due in part to to a decrease in intensity of care, especially at the end of life, coincident with an increase in hospice and palliative care nationally. There have been a number of studies that have been interested in looking at this issue. Does palliative care save our healthcare system money? We've done a few within our center. This is one looking at inpatient palliative care consultation at the University of Washington Medical Center and Harborview Medical Center. We looked at patients who had received a palliative care consult and matched them to similarly ill patients who did not receive a palliative care consult. And we showed that those with palliative care consultation had significant reductions in their costs. And importantly, the proportion of cost savings was greater when palliative care was involved earlier, not surprisingly. 13% reduction in costs if palliative care was involved in the first 7 days. If they were involved between days 8 and 30, the reduction was 5%. And not surprisingly, if they got involved after day 30, we didn't see cost reduction. There's also a study that's been done by a group within our center that is providing outpatient palliative care at both Northwest Hospital and Harborview. And they did an analysis showing that patients seen by their service had reduced ED visits by almost 30% and a reduced hospital admissions by 20% compared to historical data for these patients. So despite the fact that they were getting sicker, this service was actually able to keep them out of the hospital and out of the ED more often. So this palliative care, I would argue, represents one of those areas where we can improve quality and reduce costs simultaneously. Saving money is not the goal, right? That's not our goal in palliative care. Our goal is to improve quality of care for patients and families and to match the care that patients receive to their informed goals. Palliative care will only reduce costs if patients are generally getting more aggressive, more intensive care at the end of life than they would choose if fully informed and have the opportunity to have good communication. But the reality in 2015 is that many patients do receive care that is more aggressive or intensive than they would choose. Okay, so that's what palliative care is and what it does. I'd like to talk a little bit about how we're doing and then focus in on communication with family members in particular, which I think has real parallels between routine critical care and care for the patients who may become organ donors and their families. How are we doing nationally in terms of changes in end-of-life care for Medicare beneficiaries? This is a study done by Joan Tino looking at patients over age 65 enrolled in Medicare, comparing three time periods, 2000, 2005, and 2009. In blue, what you can see is that over that time period, the proportion of patients who died in hospice almost doubled, 20% to 40%. So significant increase in growth in hospice. Unfortunately, a fair bit of that growth was for patients seen in hospice only the last 3 days of life. Really a time period in which hospice really doesn't have the time to do what they intend to do. Also importantly, the proportion of deaths where patients spent time in the acute care setting in the last 90 days of life increased, and the proportion of deaths where the patients spent time in the ICU in the last 30 days increased. So we're seeing increased intensity of care over time, an increased number of transitions across these care settings, which I think raises real challenges for our system. This is a study that we did looking at Medicare data, looking at the proportion of deaths preceded by CPR for patients over age 65, for hospitalized patients. And again, we saw increased intensity with an increase in the proportion of patients receiving CPR over this time period, increasing for all races, and the increase was steeper for non-white races. So despite the growth of palliative care and hospice and our focus on this area in general, we really are seeing an increase in intensity of care, and I think there are a lot of opportunities to improve the way that we do this. Well, how about when we're making decisions in the ICU setting? What do we know about that? We know, and you all know, most of the time we're not able to talk to patients, particularly if they have severe brain injury or critical illness. Most of the time we have to communicate with family members. And if you ask family members what's important to them about the skills of the clinicians they're working with, they actually rate our communication skills as equally or more important than our clinical skills. And that surprised me at first, but if you think about it, it's really how we communicate with families that allows them to understand what's happening and the kind of care that their loved one is receiving. And again, no surprise to anyone in this audience, families in these contexts are under immense burdens, high levels of anxiety and depression. I don't show that data to surprise you. I show that data to make the point that we have to adapt the way we communicate with family members to take this into account, to understand that they're under a lot of stress, high levels of anxiety and depression, and that it's difficult for them to understand what we're saying, and we have to adjust our approach to address that. We've been very interested in how this communication occurs in family conferences and what we can learn from family conferences. And we did a study where we audio taped 52 family conferences that occurred at 4 hospitals in the Seattle area. And we screened all the ICUs for family conferences. When we identified one, we asked the attending physician if they'd be willing to have it audio taped. They almost always said yes. And we asked the families if they'd be willing to have the family conference audio taped, and they said yes about 3/4 of the time. So we audio taped these, and it gave us a lot of information about the kind of communication. We also surveyed family members after, asking them to rate the conference, to give us information about what kinds of things that clinicians did was associated with higher family ratings. These conferences were on average 32 minutes long. Although if you ask clinicians, they often feel like these are a lot longer. We also looked at what proportion of time families spoke and what proportion of the time clinicians spoke. So what proportion of time do you think families spoke in these family conferences? Not quite as bad as 10%. About a quarter, a little over a quarter, between a quarter and a third of the speech was family speech. A little over 2/3 was clinician speech. And we were interested in whether either of these statistics was associated with family ratings of the quality of communication. So on these surveys, we asked family members on a scale from 0 to 10, how well did the physician leading the conference do at communicating with you? There's a significant correlation with the proportion of family speech, and it's a positive correlation, meaning the higher the proportion of family speech, the higher the family rated the physician's communication skills. There was no association with the duration of the family conference. We also asked, how well did this conference meet your needs? Again, same finding. The higher the proportion of family speech, the higher the family rated the conference meeting their needs. This is observational data, but it suggests that one of the ways that we can improve our communication with families in these critical illness situations is talk less, listen more. We also asked we looked to see if there were specific things the clinicians said that were associated with higher family ratings, and there were. There were 3. Assuring the family that the patient would not be abandoned prior to death. Assuring the family the patient would be kept comfortable and not suffer prior to death. And providing explicit support for the family around whatever decision was made. And it surprised me how often clinicians didn't do this. Families would make a decision, whether it be about organ donation or withdrawing life support or continuing life support, and the clinicians would say, okay, if that's what you want to do, that's what we'll do. Rather than taking that simple step, saying, based on what we've learned from you about this patient and about your family, this seems like the right decision. We also looked at whether there were missed opportunities during these family conferences, and we found that they fell into 3 categories: missing the opportunity to listen and respond, answering questions and clarifying and following up on family statements. Sometimes there'd be a question asked and there'd be no answer. That wasn't very common. What was more common, the family would ask a question and the clinician would answer a different question. So the family would ask about prognosis for neurologic recovery, and the physician would talk about the Glasgow Coma Score, which is not the same thing. The second category was missing the opportunity to acknowledge and address emotions that come up. And the more I am in this field, the more I realize how important this is. You know, a lot of us physicians in particular are trained to think these decisions should be cognitive, not emotional, right? That is wrong. These decisions are always emotional, and you have to deal with the emotions before you can move on to begin to think people can think about the cognitive decisions. And then the third category, what we called missing the opportunity to address basic tenets of palliative care, exploring patients' preferences, explaining the principle of surrogate decision-making, that the family is really not there to say what they would want if they were sick or even what they want for the patient, but rather what they think the patient would want. And then affirming non-abandonment. I think that's a really important one as well, and it brings in the importance of having a program for grief and bereavement. And it's one of the opportunities to involve palliative care and hospice, because they will provide that. So we took all of this information and we put it together in a mnemonic. We wanted a teaching tool that we could use to teach clinicians about conducting family conferences. We came up with this mnemonic. Actually, a nurse who's been working with me for a long time, Patsy Treese, came up with this mnemonic, and I took credit for it. And the mnemonic is value. V is explicitly valuing the family statements and how helpful that is to have information from them. A is acknowledging family's emotions. L is listening, again, back to that important feature. U is asking questions that allow us to understand who the patient is as a person. And then E for eliciting family questions, and not just once, but multiple times during the family conference. And then we had an opportunity to test this mnemonic in a randomized trial that was actually conducted in France, so it was translated into French, in which they identified patients in the ICU who were going to die within a few days, and they randomized them to either routine care or to an intervention which asked the clinicians to have a family conference that day and to use this value strategy. They also had a bereavement pamphlet that they gave family members. And their outcomes were to follow up with family members 3 months after the patient died and to measure symptoms of anxiety, depression, and post-traumatic stress disorder using validated surveys that measure these symptoms. And I think this study had 2 important findings. One was that the level of symptoms amongst these family members was really high. And the second was that this relatively simple intervention that just asked clinicians to use this strategy to communicate with families resulted in a dramatic reduction in these symptoms of anxiety, depression, and PTSD. So I believe that family conferences are one of the places where this conversation happens, not the only one. We also do a lot of communication at bedside. We do a lot of communication on the phone. It's all important, but the family conference is really an opportunity, I think, to provide support for families and to help them through difficult decisions. I think we ought to view the family conference as one of the critical ICU procedures that everybody has to be trained in and know how to do. It should be just like putting in a central line or a lot of the other procedures we do. We need to make sure that these are done well. We've developed a system of trying to really make sure that we train fellows, critical care fellows, but also residents and nurses working in our ICUs as well on how to run an effective family conference. When I'm teaching this, I like to think about what happens before, during, and then as you wrap up. And I think one of the most important tips for running a family conference that I'm going to say is make sure that there's a pre-conference where all the clinicians who are going to be there are sitting around talking about what our goals are, what we want to accomplish, and make sure that everybody is on the same page. Critically important. Doesn't happen enough. Some of the worst family conference disasters I've seen have been because clinicians were not on the same page saying very different things. Sometimes they're not on the same page, and sometimes they can't get on the same page. I acknowledge that. But at least you can develop a strategy for how you're going to work with that and how you're going to present that to the family. We also need to make sure that we're prepared, that we have the prognostic information we want, both prognosis for survival as well as quality of life, that we have our facts right about the case and the right people in the room, both family members and clinicians. Very important to start with introductions, even if everyone's met everyone. I really like to start with introductions. It gives everyone a chance to use their voice at the beginning of the conference, and I think it lowers the barriers for some family members to speak up. And then we often ask family members for their understanding, and I think this is really helpful to hear what the family has heard, what they understand. It's very important that it be done in a way that doesn't feel like a test. And so I think having language that makes family members comfortable is key. I like to say you've talked to a lot of clinicians. It would help me to know what other people have told you. So you're not putting it on the family, you're putting it on the clinicians. Then we often provide an update or an overview. The key there is to keep it simple, keep it brief. If they want more information, they can ask for it. In these family conferences that we audio taped, we started to call the clinician's initial giving information the opening monologue. And the opening monologue sometimes went 8 minutes uninterrupted. I mean, think about that, 8 minutes uninterrupted of medical information. Who can track that? And then it's really important that, okay, we've given our information. Now let's hear from the family. Tell us what you're the expert at, this patient, their values, their goals, what they wanted, what was important to them. Sometimes it's important to flip this around and actually start there. It really depends on the goals of the conference. And then making sure that we respond to emotions and express empathy. This is a rough guide. I think we can't think that this can be rote or done the same way every time. If there's a family conference where they're sitting on the edge of their seats waiting to hear what the second brain death test showed, don't start by asking them what they think they understand and talking about the patient's values, right? They want information, and sometimes we have to adapt this to that. Then we often discuss options, and I think it's so important that we make recommendations. Most family members want our recommendations. We've trained a generation of physicians Fortunately not now, but in the last 5 or 10 years, we trained a generation of physicians to not make recommendations in these difficult situations. That's not what families. There are some families who don't want recommendations. You can usually tell that, but most families want our recommendations. And then it's important that we finish by summarizing and making sure that we ask for questions. Sometimes in these family conferences, our job is to give bad news. This happens with brain death as well as with other situations. And I think in this situation, I really like this teaching mnemonic developed by Walter Bailey called SPIKES. And there are some similarities between this and what I've been talking about in terms of family conferences, but making sure that we have the right setting, quiet, private place, that we have the right people there, and starting by asking what people's perceptions is, what's their understanding of what's going on. It can really help us understand how to frame what we have to say. The next piece feels a little awkward at first. It's an invitation, asking for an invitation to give the bad news. And you know, in the ICU, and particularly in brain death, if somebody says, no, I don't want the bad news, that may not be an option, but at least you know where you're starting. And what I find is that this invitation, asking for this invitation, families almost never say no. But by doing this, you're preparing them. They steel themselves, they get flooded a little bit, and then they're ready to listen. And I think it's much more effective than just blurting out the bad news. And so I like to say something like, I have some bad news. Are you ready to hear this? Then we give the news in a clear, succinct, and brief way. People will ask for more information if they want it. But we've also trained a generation of physicians to present on rounds, right? And to give a lot of information and very detailed information. And that's not helpful for families in these really stressful situations. The E in SPIKES, again, important, acknowledging the emotions and responding to those emotions, and then S, summarizing and reviewing the next steps. One of the key pieces of bad news we give, and particularly in the organ donation context, is explaining brain death. And I think here clear language is really important. I'm really sorry to have to tell you that your father, your son, has died. It's so important that we use that word, died. And then I think we generally have some explaining to do, because many people don't understand brain death. Some family members may have more questions about this. Some family members may be very educated and want to know a lot about how the brain death test was done, and I think it can be very helpful to go into those details for some, if they want it, but not routinely, in my opinion. Some family members may want to be there for the brain death evaluation, and I think for some family members that can be very helpful as well. So let me finish up by talking a little bit about the potential collaboration between palliative care and organ donation. And I would argue that it's key to understand the role of both primary and specialty palliative care for patients with serious illness and their families. And you all, working with these patients and families, you practice primary palliative care. This is what primary palliative care is. If you're a palliative care specialist, then you have specialty training in this, and you're there, you may be called to help support families in decision-making, particularly in difficult situations, to provide grief and bereavement support and to help set that up down the road. And palliative care providers are also trained in helping families think about legacy work. Very important for some, not all, but for some families to think about what is this person's legacy. A legacy is a gift that comes from our experiences, challenges, and successes in life. And we can pass this gift on to future generations by sharing our stories and our wisdom. Legacies can offer the bereaved a tangible way to remember the deceased. It's really a gift of remembering. And it leaves something behind that can transcend death. And organ donation, for many family members, is a type of legacy. This is and can be viewed by families as doing legacy work. And you saw that in the video that was played right before I started. This is part of, it's not all of the legacy of that young woman, but it's part of it. Legacy work can be done by patients, generally not brain-dead patients, but it can be done by patients who are ill and are looking at their own mortality. It can be done by family members when patients are not able to participate. And I think it's a nice way, at least I find, to fold the organ donation process into this grief and bereavement phase of caring for family members. So let me just finish up by talking a little bit about our Cambia Palliative Care Center of Excellence. This was started, our center was started 2.5 years ago, and then just this past winter, we got this gift from Cambia, and we renamed ourselves the Cambia Palliative Care Center of Excellence. And our mission is to improve palliative care received by patients with serious illness and their families, and to provide support for clinicians providing both primary and specialty palliative care. We do this by developing new knowledge through research, by developing educational programs and tools, and by developing clinical resources and clinical leadership to improve palliative care in UW medicine, in the region, as well as nationally and globally. This is our website. If you're interested, I encourage you to go to our website. On our website, up on the top, you can, on the red dot, you can donate to us if you choose. But right below that, there's a button that says Become a Member. And you can become a member. It doesn't cost a thing, except the willingness to receive occasional emails about what we're doing and our programs that we're offering. You can, through becoming a member, help develop and use the resources that we have for patients and families, as well as clinicians, and participate in events as well. I meant to include a slide, and I didn't, about an upcoming educational event I do want to make people aware of. We're doing a 2-day educational conference in Seattle on palliative care, April 27th and 28th. And if you're interested in that, I'd encourage you to visit our website and register. So in summary then, what I've been trying to cover is to make the point that palliative care improves outcomes for patients and their families, improving symptoms and quality of life, reducing unwanted intensive care, and supporting family members, and that palliative care is delivered by all clinicians who care for patients and also by specialists trained in palliative care. That understanding palliative care, I believe, is important for the organ donation process, to support families through this process. It's important that we know how to work with the palliative care specialists. We were talking at the beginning about how there's an opportunity for the organ donation staff to interact with the palliative care clinicians to make sure we're on the same page and working together to support the families. And I think it's important to understand that you all provide primary palliative care every time you work with the family members of a patient who's considering, or a patient who's being considered for organ donation. So with that, I'll stop and thank you for your attention and see if there are any questions.